Okay, well, I think we'll get started. So, thank you all for tuning in. Today's webinar is laser therapy for tennis and golfer's elbow. My name is David Kanashko. I'm a chiropractor, also the Director of Education and Training here in Toronto for Bioflex Laser Therapy. So, a few housekeeping measures, just again, so everyone is aware, this webinar is being recorded and will be edited and posted on our support page, which is password protected, within about a week or two of the original broadcast date. If you have any questions, please type them in as we go along, and I'll get to those questions at the very end of the webinar. And any comments with respect to topics, that kind of thing, please email me as well. Okay, so let's get started. This topic, and in particular tendinopathies, is one that I've done a lot of research in, and I'm very interested in learning more about it. I've been treating these types of conditions for a long time, and they're notoriously difficult to treat, whether they're in the elbow or other areas of tendons. So I felt that this would be a good topic to discuss, to try and understand the pathophysiology of what we're trying to deal with as clinicians, and that way we can better, treat these problems and get better results. So that is really the goal of today's webinar. I'm going to talk a bit about anatomy and pathophysiology of the tendons at the elbow, and specifically of the tendons themselves. I'm going to talk a bit about eccentric exercises, which are critical in helping these conditions get better. And then, of course, the role of photobiomodulation. Notice I'm using this term now, photobiomodulation, or PBM, T for therapy, or, of course, we all know it as low-level laser therapy or low-level light therapy. That term is becoming a little antiquated now as the research shifts towards using the medical science library term photobiomodulation. I'll go over a bit of research on this topic, and lastly, I'll talk about targeting and treating this elbow condition with Bioflex laser therapy. So, quick review. I'm not going to spend a lot of time on the gross anatomy. We're all pretty much aware on the lateral aspect of the elbow, the common extensor tendon, where it inserts, and of course the multiple muscles, extensor muscles that come to form that tendon into the bony portion at the elbow. It's my understanding that if you look at all these muscles, one of the more commonly affected muscles is the extensor carpi radialis brevis. However, they can all be involved as well. When you're treating this type of condition, you have to look at both the pathology at the actual extensor tendon, but also trigger points or myofascial issues in the muscle bellies themselves too. So don't ignore that aspect when you're treating. On the flip side, the flexor side, again, you have the common flexor tendon inserting on the medial aspect. This is typically called golfer's elbow, whereas the lateral side, as you know, is tennis elbow. Although, of course, we all know that either or can be you can get this condition not necessarily by even playing those sports, but you can get tennis elbow with golfing and vice versa, or what have you. So let's look at the pathogenesis. This is really important. Maybe a review for some of you, or maybe for all of you, but perhaps this is just a good refresher as to what we're trying to deal with. Really, this condition oftentimes was referred to as epicondylitis or a tendinitis kind of scenario. However, histopathologically, there's actually very few inflammatory cells, especially when it becomes chronic. So there aren't really as many macrophages and neutrophils there in this condition, in this chronic state, which lends itself that it shouldn't be called an inflammatory condition. In fact, it's more of a chronic type of condition. So the term really, for most of these patients coming in, it's a tendinosis condition, but we'll talk about the differences as we go along. So this is more of a degenerative process as opposed to an acute process. That being said, there are well-defined histological stages that result from repetitive microtrauma. So stage 1 is that acute stage. So this is where you have an actual acute inflammatory response. This is where you can call it a tendinitis kind of condition. that's where someone was outside, their elbow's normal, then they did, a lot of hard raking, or they did something, and then all of a sudden later that day or the next day it's flared up, it's hot, it's red, it's obviously inflamed. This is a true tendonitis condition. However, most patients don't come in and present with this scenario, but that is considered the first stage. It can even occur in a tendinosis scenario where you've actually injured or freshly injured a tendinosis and causing acute flare-up as well. In stage 2, if the microtrauma is sustained over a period of months or years, there becomes a concentration of fibroblasts, a specific vascular hyperplasia, and disorganized collagen fibers appears. This is defined now as a tendinosis condition. So this stage 2 is usually where patients are coming in for treatment. They have chronic elbow pain. It can become quiescent and then flare up when they start to do a few things, kind of generalized ache. Oftentimes they just get to the point where it's really nagging and it starts to become incapacitating. Into stage 3, where the condition's been around for quite a long time, you can start to see pathological changes. This might lead to actual failure of the tendon, whether it's partial or even complete rupture in cases. Of course, that would require surgery. But as things go along into stage 4, you'll start to see repair of the tearing, and you'll start to see fibrosing, even soft matrix calcification. You'll see lots of possible osseous calcifications as well. So that's obviously near the end stage. And again, most patients are coming in the stage 2 type of scenario. So let's take a little bit more detailed look at a tendon. So you can see here that we're looking at a macroscopic and microscopic view of tendons. When we blow that up, we of course are looking at the tendon sheaths or microsheaths, and within them you'll see tenocytes or tenocytes. These are tendon fibroblasts. So essentially they're fibroblasts that secrete collagen, and specifically they're found in tendons. So these are the really critical cells that need to be functioning normally in order for the collagen pattern to be maintained. You can see that collagen is nice and neatly aligned, parallel fibers. These are type 1 collagen fibers that give the tendon integral strength and elasticity. Okay, so that's what it normally looks like. What's really interesting is that the tenocytes or tenocytes communicate via gap junctions. So what they found is when tenocytes are stimulated, they can communicate with each other almost like nerve cells, and in essence help to repair a damaged tendon. So if you look at this a little bit more carefully, if there's mechanical loading on tenocytes, this stimulates protein synthesis via tugging of the cytoskeleton that sends a signal to the nucleus, and then a release of biochemical signals that increase gene expression. So mechanical loading is critical for the repair process of a damaged tendon because it will stimulate this gene expression and production of collagen over a period of time. This does take a long time, okay? So we need to understand that when we're treating these patients. So definition-wise, if you're talking about a tendinopathy, and that's either a tendonitis or a tendinosis, this is essentially defined as a clinical syndrome. There's pain, there's swelling, and there's functional impairment. The pain, though, is different in a tendonitis and in a tendinosis. A tendinosis is, again, more common than a tendonitis, and again, it's a degenerative, non-inflammatory process unless it's gone acute, and it has disorganized collagen structure, and I'll show you a picture of what I mean by that shortly. Whereas a tendonitis is a little bit rarer. It is an actual inflammatory process, as I mentioned earlier, and that's really due to an acute micro-tearing of an overloaded tendon. That could be, taking a swing in tennis or golf, or what have you, and you feel sharp pain or what have you, and you've actually torn some tissues, which responds by an acute inflammatory process. This is what we really need to be concerned with as far as clinicians. If you look at the time to recovery in a tendinosis with an early presentation, that could be 6 to 10 weeks. In a tendonitis condition, that could be only a few days to a couple of weeks. So let's say a patient presents a perfectly normal elbow, no prior history of a problem. They go out and hit 5,000 balls at the golf range, and next thing you know, they have an acute tendonitis. Well, if they rest it up, get some treatment, excuse me, oftentimes that will resolve fairly quickly. However, if it's a tendinosis condition, then you're looking at quite a few weeks. Now, if the presentation is chronic, it can take many months, upwards of 3 to 6 months or even longer for tendinosis. Or tendonitis that didn't resolve, it can take up to 4 to 6 weeks. For tendinosis, our real aim here is to encourage collagen synthesis and strength, and you're trying to repair the damaged tendon. For tendonitis, of course, you want to repair it, but at the same time, you want to reduce that inflammation as quickly as possible. So, you might look at some non-steroidal anti-inflammatories in the case of a tendonitis, although I don't recommend them, but oftentimes they are used. What you definitely don't want to do is use anti-inflammatories for a tendinosis condition. So if a patient says, yeah, I'm popping some NSAIDs, whether it's Aleve or what have you, it's definitely not going to help the cause. In fact, it may be detrimental. So be aware of that as well. Age is commonly associated with increased prevalence of these degenerative changes, such as decreased cellularity, increased glycosaminoglycan content, and lack of fiber organization. So you tend to see tennis elbows in middle-aged patients, in their 40s and 50s, that kind of thing, a bit more commonly than in younger patients. Younger patients, you'll tend to see more the tendonitis type of scenario. So the aging tendon loses its elastic properties, causing the muscle to work more with subsequent tendon changes. Symptom-wise, for tendinosis, you're looking at intermittent pain that can be related to exercise or activity, as opposed to tendonitis, which has pretty much constant pain because it's an acute inflammatory process. With tendinosis, you're going to have quite a bit of stiffness, especially upon weight bearing, doing things with the elbow after prolonged immobility, or whether it's sleeping or just not doing anything. There's a lot of stiffness and pain at the commencement of an exercise that feels better as the exercise continues. So oftentimes these patients are saying, yeah, I'm still playing golf or tennis or whatever. Yeah, it hurts a little. It hurts when I'm start to play, but then it feels all right. And then the whole scenario starts over again. So you do really have to be aware of this when you're treating these patients. And I know a lot of golfers. Personally, I'm not a huge golfer myself because I suck at it, but golfers are notorious for not wanting to stop playing golf. And so you do have to kind of lay out the ground rules if you want these patients to get better. As the condition worsens, there's a progression of the pain felt towards the end of the exercise session to right throughout the duration of the activity. So it's getting worse if they're saying that their elbow pain is bothering them right through their entire golfing match. Microscopic view of tendinosis, it will reveal a much higher percentage of immature type 3 collagen fibers. I have a picture of that shortly. There's increased amount of ground substance. There's what's called haphazard vascularization. These are blood vessels that actually don't support the tissues very well. And there's a loss of collagen continuity, so that the fibers tend not to be as well aligned with each other, and sometimes fail to cross-link together to facilitate load bearing. So in other words, it becomes weaker as this condition progresses. So just a electron micrograph view of normal tendon type 1 collagens. You can see the bands, nice and parallel fashion. These are type 1 collagen fibers. In a tendinosis condition, you can see it's immature type 3 collagen, more like a spider's web, not parallel aligned, much weaker, easier to tear, easier to injure, and definitely not very healthy. So again, tendonitis is the inflammation of the tendon and results from micro tears that happen when the musculotendinous unit is acutely overloaded with a tensile force that is too heavy and or too sudden, as I mentioned earlier. And it's hypothesized that many cases of tendonitis, especially in older people, by older, like greater than 20, 30 years of age, occurs secondarily to tendinosis. So they might have two conditions going on, so be aware of that as well. Chronic tendon injuries, again, are degenerative in nature. I keep emphasizing this, and are not inflammatory. NSAIDs, corticosteroid injections, can actually accelerate the the degenerative process and make the tendon more susceptible to further injury, longer recovery time, and may increase the likelihood of ruptures. It used to be very common to get cortisone injections for tennis elbows. Unless it's a very standalone acute tendonitis scenario with no underlying tendinosis, you're actually causing the patient more potential risk for problems down the line. So it's not recommended at this point, based on the research, to have cortisone injections. What you want to do is heavy load eccentric strength training, which helps to increase the tensile strength of the tendon. This increases the amount of type 1 collagen and decreases the amount of ground substance, thereby reducing tendon volume and helping restore the tendon to a healthier state. So tendinosis tendons tend to be thicker, greater volume. You can usually palpate this difference. It's harder to see in the elbow, but in the Achilles tendon, it's really easy to see that scenario. Here's an example of eccentric exercises for golfer's elbow. The patient, they can do this in different ways, either using an elastic band or a weight. You can see the patient, their palm up. So what they're doing is they have the TheraBand applying tension, and the hand is, again, face up in an extended position. And then you take the opposite hand that is healthy, hopefully, and without using the right hand in this scenario, you actually lift the wrist and hand all the way up into a complete flexed position, let go with the opposite hand, the left hand, and then against resistance, slowly let the hand all the way down back into the complete extended position. And then you repeat. Generally speaking, they recommend 3 sets of 50 with a few minutes in between each session, using increasing weights or TheraBand strength or elasticity. These tend to be painful, which is fine. If it causes too much pain, then you have to sort of ease off on them. But having pain during the exercise is pretty normal. And these are the number one most evidence-based type of therapy for a tendinosis condition, whether that's Achilles or at the elbow. So just be aware of that. I didn't show you the one for tennis elbow. You just obviously, instead of having the hand in the flex position, you rotate it pronate supinate so that you have the arm and the hand facing downwards in the extended position or the flex position. Okay, so tendon healing is a continuous process because tension across fibroblasts causes these cells to divide and to align perpendicular to the line of stretch. Tendons require sometimes well over 100 days to make new collagen. That's why it's important to talk to patients about the repair process and the length of time it takes to repair. This concept really extends into an analogy of Wolff's Law, as you're, I'm sure, aware of, which states that tension on maturing granulation tissue may lead to the development of preferential direction of collagen in the fibers. So in other words, if you stress collagen and the tendinocytes or fibroblasts in a certain direction, it's laid out in that direction. So if you keep doing that, then the collagen is going to be lined up more parallel fashion than if you just kind of, don't move that tendon at all. So it's really important to understand this when you're trying to get these patients better. So now that brings us to the role of laser therapy. Obviously, it's going to improve collagen fiber organization, this parallel alignment. It will increase the synthesis of type 1 collagen due to proliferation that has to do with the ATP production in the tenocyte or tenocyte. It downregulates something called MMP or matrix metalloproteinase, which normally degrades the matrix proteins. And it can decrease inflammation if present by increasing anti-inflammatory mediators and decreasing pro-inflammatory mediators. It will upregulate IGF or insulin-like growth factor. This increases cell proliferation and matrix remodeling. It can reduce fibrosis and has a critical role in increasing ROS or reactive oxygen species, which are chemically active molecules that play a very important role in cell signaling, which eventually leads to increased protein synthesis. Okay, let's take a look at the scientific research. There's a fair amount. I just focus on 2 things here. One was an evidence-based article by the British Medical Journal, and it was specifically on tennis elbow. So what I thought was really interesting, they laid out some key points. First of all, lateral elbow pain affects about 3% of the population at any given time. It's usually an overload injury, we know that, a minor trauma, what have you. What's really interesting is they noted that although it's usually self-limiting, which is true, symptoms may persist over 1 year or longer in up to 20% of people. So a fair percentage of patients will have chronic problems, and oftentimes it's these patients that we see in the clinic. So these were the key points as far as what was effective or what wasn't effective. Extracorporeal shockwave therapy, acupuncture, exercise, mobilization, braces, manipulation, surgical techniques, and so on and so forth. Again, not necessarily all having very good evidence. I would note, though, by exercise, there has been a fair amount of research on eccentric exercises that has been shown to be very effective. But these other types of treatments, there's still not enough evidence, although they may be helpful. As we know as clinicians, you may be using these, but not a lot of good evidence out there to suggest that they are more effective than anything else. However, and you probably knew this was coming, is that they did say that low-level laser therapy was effective or likely to be beneficial for both short-term pain relief and improved function. So that was one of the key findings of this clinical evidence guideline by the British Medical Journal of Musculoskeletal Medicine. A research paper looking at 324, or sort of randomized control trial, it was double-blinded, looked at 324 patients with medial and lateral epicondylitis. Now, this is a little bit old paper, but I like it because it was a multi-center research program, and they were using 830 nanometers, 630, so that's red and infrared wavelengths. They treated both trigger points and tender points in and around the elbow. They did anywhere from 3 to 5 treatments a week, and with a total of anywhere from 6 to 24 sessions. So it did vary according to the center that was doing the treatment. It gives you an idea of the number of sessions that might be required. The terminology they used, by the way, was the old terminology. More than likely, many of these patients actually had tendinosis as well. So outcome measures, they looked at the McGill's Pain Questionnaire, they had a VAS, they had a verbal rating scale, patients had pain diaries, and they also checked the grip strength through a dynamometer. The results were total relief of pain with consequently improved functionability. This was achieved in 82% of acute, so more of the tendinitis scenarios, and 66% of the chronic cases. So really good overall results with those two wavelengths. And again, they correlate exactly, well, within 20, 30 nanometers for the red of the wavelengths that we use in our equipment. Okay, so how do we approach tackling this condition? The placement of the array, essentially, and I'm showing you here the placement of the dual array over the lateral epicondyle. Again, if this was a medial epicondyle, you would just rotate it around to go over the medial epicondyle. And then you can do a second placement if you're finding that there's a fair amount of trigger points or pathology in the muscle belly. So you can do the first one on the left, and you could, if necessary, customize and put in the second position as well, overlying the extensor or flexor bellies, depending what you're treating. As far as the probe goes, in this example, for a lateral epicondylitis, you want to make sure that you spend a fair amount of time over the insertion of the common extensor tendon at the elbow, at the epicondyle. And of course, as I mentioned, you want to make sure that you treat trigger points or tender points in the muscle belly, especially focusing on the extensor carpi radialis brevis, because that does seem to be the muscle belly that's most involved, although other ones obviously are as well. Protocol-wise, we do have a specific epicondylitis protocol. So this is in an acute scenario, a true epicondylitis. The initial setting for stage 1 is continuous wave with red light for about 8 minutes overlying the epicondyle and or the muscle belly. So you might want to do 2 placements here. And I'll show you the time frame. And then the infrared array, you're going to have it modulated 10 hertz, so 10 cycles per second, 40% duty cycle. So it's relatively low on the frequency and duty cycle because it's an acute scenario. Again, a fairly lengthy treatment time as far as 8 minutes on that array. What we're trying to do here is really facilitate anti-inflammatory mediators to help control inflammation. And of course, we're going to use the infrared probe. Make sure it's set at 40%, maybe even lower, maybe even 20-30% if it's a really acute scenario, for roughly 5 minutes. And again, remember, you're going to be holding it for a certain amount of time on each spot, and I'll review that in a second. If the patient, if the patient is presenting more of a chronic scenario, so a tendinosis scenario, I would stick with the dual red continuous wave about 8 minutes. However, when we use the infrared, you can see here we're going to be a little bit more aggressive with respect to the frequency and the duty cycle, a little bit more dosage, trying to get a bit more light into the tissue. And the goal here is to really try to stimulate tissue repair of the tendon and or the muscles that are involved. So the difference between a tendinitis and a tendinosis condition is decrease the frequency and duty cycle for an itis and increase it for an osis or a chronic condition. Hopefully that makes sense to everyone. And again, you're going to use the infrared probe, again, 40%. I think you're okay to start at 40%, maybe even 50%, and you can be a bit more aggressive with respect to increasing the percentage time of the probe for a tendinosis condition. Okay, so review, make sure the probe is parallel, good contact, apply overpressure into the tissue to make sure that you get the light into the tissue as deep as possible. You're going to hold the probe anywhere from 5 to 8 seconds. Over the tendon, maybe 3, 4, 5 seconds. Over the muscle belly, maybe 8, 9, 10 seconds, depending on how much muscle tissue there is you're trying to treat. Don't forget to treat the trigger points. If you've done all the points, you can go back to the trigger points and treat those. If you have a red probe, it's very helpful for pain, for reducing pain in these types of conditions as well. If it's an acute scenario or really even a chronic scenario, it's very helpful if you can get a patient in the first 3 or 4 days on consecutive days to treat. Thereafter, treating 3 times a week, every second day is what we usually recommend. Then eventually reducing it down to once a week as they improve. The typical treatment plan, again, on the low side, 12 for more of a tendinitis condition. On the high side, 24 or even more treatments. Again, over 2 to 3 months for tendinosis, maybe over a month or less for a tendinitis scenario. So you want to address potential underlying causes as well. So if they're repetitively overusing it at work or sports or whatever, you want to make sure that you address that with your patient as well. Okay, well, that's it for the information. Just a reminder that we have a certification training here in Toronto coming up in August. Actually, we have one this weekend, but it may be a little too late if you're interested in doing that. However, in August 18th, 19th, we have one coming up, and then in Calgary in November 17th, 18th. And we're also having a master class, by the way, in Calgary. If you happen to be in the area or can get to Calgary, we're on the 19th. I believe it's up on our website as well that we're doing a master class. We have quite a few external speakers, so it should be a really good event. Upcoming webinars, I haven't posted these on our website, but I shall shortly. On August 17th, I'm going to talk about plantar fasciitis and heel spurs, always a real fun condition to treat. Then a generalized webinar on muscle strains, how to appropriately treat muscle tears or strains. And then in October, a webinar on lumbar disc herniations. So let's see if you have any questions. So I'm going to just take a look here and see if you guys have typed in any questions here. So I have a question from Jill. If there's ligament damage as well as tendon damage in the elbow, will there be collagen increase in the ligaments as well? Right, yeah, so Jill, so for example, if say you do have some ligamentous damage as well too, literally the treatment will also help those ligaments as well. Another question here is, I've been told that ligaments have no blood flow or reduced blood flow, and that laser doesn't help with ligaments. Well, actually, yeah, it really it does. So there is poor blood supply. Actually, there's poor blood supply to tendons and ligaments, but that's why they take so long to heal. But there is some vascularity in and around ligaments and tendons, and so in fact, you can help with the healing of ligaments and tendons. And actually, there's actually tons of research to show that it on a microvascular level that's very helpful in treating ligament damage and tendon damage as well too. So I would sort of disagree with the fact that it wouldn't help ligament repair. Okay, that's it. I want to thank everyone for tuning in. Always appreciated that you do that and take your time, and hopefully we'll see you next month. Take care.